We're going to discuss the normal liver. We'll talk about Doppler of the hepatic vessels. We'll talk a little bit about diffuse liver disease patterns, then move into portal hypertension and focal liver masses. Now the normal liver, when we look at it sonographically, we pay attention to the size of the liver, the shape of the liver, the echogenicity, and the echotexture. The echogenicity and echotexture are two different things that we talk about. Echogenicity has to do with the level of brightness of the liver parenchyma, and we use portal vein walls to compare that. And texture has more to do with the homogeneity of the liver. The liver is very susceptible to technique. We have to make sure that we have a nice smooth TGC curve. We want to make sure that the penetration goes all the way back to the diaphragm. Here is this curvilinear bright structure. We would like to have the vessel wall, vessel lumens clear of extraneous echoes. And when we scan the liver, we want to make sure that we clear all of the margins of the liver. In this case here, we have very good technique coming through this side of the image. We have nice echogenicity, clear vessels. We get through to the diaphragm, but here we seem to have some kind of division, some kind of dropout of sound, so we would have to correct that, either apply better pressure on the abdominal wall and try to even out the echogenicity here of the liver. One thing that's very important, and this is important for all structures that we image in ultrasound, we always want to be able to see at least 2 to 3 centimeters beyond the margin of any organ so that we can exclude possibility of any exophytic masses or any kind of adjacent masses that can affect the organ. In this case here, this is the liver. The inferior edge of the liver would be here, but because we were trying to clear 2 to 3 centimeters beyond the margin, we noticed that there was a mass hanging off the inferior edge of the liver. We would have never seen it if we would have stopped our picture at the inferior margin of the liver. And if you, by the way, this was a hepatocellular carcinoma, a hepatoma, 5 centimeter hepatoma hanging off the margin of the liver. And if you think that this is an anecdotal or unusual case, here's another case that we had fairly recently. Hanging from the inferior margin of the liver was this large mass, another hepatocellular carcinoma hepatoma, and that's the right kidney here. Now, as you scan the abdomen, you should always have in mind the different parenchymal organ echogenicities and have a kind of a relative scale in your mind of the different echogenicities. The renal medulla is the least echogenic of all the parts of upper abdominal organs. It is much less echogenic than the cortex of the kidney, which in turn is less than or can be equal to echogenicity of the liver. We used to think that equal to the liver was abnormal, but now we know that especially in young people, cortical echogenicity could be equal to liver echogenicity. Now, we also know that the liver is less echogenic than the spleen, but that's something difficult to ascertain because usually the liver and the spleen are not on the same picture, and you would really need them to be side by side to tell which one is more or less echogenic. That can happen sometimes. Now, this is a scan of the left upper quadrant, and we're looking at the spleen here, and we notice that the spleen has sort of a double shade, has a darker area and a brighter area, almost like a double shaded spleen. However, we also note that there are some little vessels in this part of the spleen, not so much seen here. And then we realize that this is liver. This is the left lobe of the liver going all the way across to the left, hugging the spleen, and so that it looks like it's a part of the spleen, and it isn't. So this is liver, which is indeed less echogenic than spleen. And this is not to be mistaken for a subcapsular hematoma. Sometimes this is mistaken in the spleen. So there's our proof. Now, The liver is also less echogenic or equal in echogenicity to the pancreas. Pancreas usually more echogenic, but they can be equal, especially in younger people. So here is pancreas, and here's the left lobe of the liver, and they're fairly equal. When we compare echogenicities, we should be comparing at a similar depth of the beam. Oh, and one more thing here, that the pancreas itself is less echogenic than retroperitoneal fat, which is hyperechoic, and also less echogenic than the renal sinus echoes. So renal sinus echoes and the retroperitoneal fat are hyperechoic and the most echogenic of all of these parenchymal organs. When we look at the liver parenchyma itself, we realize that there are little holes throughout the liver. Sometimes we see little cylindrical shapes, and some of them have bright walls, and some of them do not. So then we have to figure out what we're looking at. When we do ultrasound sonographically, the vessels that are visible within the parenchyma of the liver are the portal vein walls and the hepatic veins. The hepatic arteries and the bile ducts typically are not visible within the parenchyma of the liver unless they are abnormally dilated. We can see them in the porta hepatis, which is just outside the liver, but as far as being inside the liver, we only see these two vessels. If you think about the liver, you realize that there are 4 tubular systems that go throughout the liver. We have the portal venous system, the hepatic arterial system, and the bile ducts. These are intimately related at the porta hepatis. They join together as partners in the portal triads, and they stay together throughout their entire branching throughout the liver. The 4th tubular system is the hepatic veins. Now, the hepatic veins drain the liver superiorly towards the IVC, inferior vena cava, and they stand alone. They do not have anything associated with them, and that becomes important to us. We'll see in a minute. So the portal triads then are maintained throughout the liver, and that's partially, that is what is causing this reflectivity of the walls. Portal veins have bright echogenic walls, and we use this for comparison of parenchymal echogenicity. What happens is the main portal vein, it enters the liver through the porta hepatis and almost immediately splits into a right and left portal vein. The largest portal veins divide horizontally approximately in the middle of the liver, and they supply lobes and segments, and they carry blood flow into the liver. Now, the reason that portal veins have bright walls is, number one, because of the portal triads, which is the portal vein, the little hepatic artery, and the bile duct. So all we're seeing here is the portal vein. The little artery and duct are small, so they just provide reflectivity. We also have some reflectivity from Glisson's capsule, from the little lymphatics and nerves and connective tissue around the portal triad. So that's why portal veins have bright walls. Hepatic veins do not. And why is that? Well, it's a matter of contrast. The hepatic veins have imperceptible margins. They actually have walls, but we just don't see them. If we look at what they look like by configuration, they're more vertically oriented. They enlarge towards the inferior vena cava, and they actually have sort of an umbrella configuration where the spokes of the umbrella come together superiorly and the rest of the spokes drop down throughout the liver. Now, these veins are found between lobes and segments, so we use them as anatomic dividers, and they carry blood flow out of the liver. They do not have any other adjacent little structures, therefore we do not perceive their walls. Here's an umbrella, just for your imagination, you can see that the spokes of the umbrella come together at the top, which is here. So if we take a slice through the very superior portions of the liver, we can see longitudinal orientation of the hepatic veins. Now, as the veins drop down and we take a transverse section lower, these veins will be cut and look as like circles. So here is the middle hepatic vein, and here is the right hepatic vein, showing us lower in the liver as a cross-sectional configuration, cross-section, which we would be doing through the spokes of the umbrella. Now, having said that, we always find exceptions to the rule. Now, I just told you that portal veins have bright walls, and now all of a sudden I'm showing you a picture of a portal vein that does not have bright walls. Some portal veins may not show echogenic walls because they become parallel with the beam. Parallel is the worst angle for B-scan. So we're losing resolution, and we simply lose resolution of this portal vein wall. Here, on the other hand, are hepatic veins. Now, I just told you that hepatic veins do not have bright walls, and all of a sudden I'm showing you a big hepatic vein with bright walls. Well, it is true that some hepatic veins may show echogenic walls. That's because they're large veins and they have thick walls, so they do have reflectivity. But also, in this case, this vein is completely perpendicular to the sound beam, and that's the best angle for B scanning. Therefore, we see the hepatic vein wall. So, two exceptions to the rule explained by angles. So we have some now a little bit of insight into the anatomic landmarks on transverse scans of the liver. And let's look at these. In high portions in the upper parts of the liver, we see large hepatic veins coming together into the inferior vena cava. In the mid portions of the liver, we see the portal veins kind of horizontally situated, the left being a little higher than the right, but nonetheless with the bright walls. That we know now that we're in the middle of the liver. If we look at transverse lower sections of the liver, we don't see any big veins. We see an echogenic line here. This would be where the falciform ligament comes in, and the umbilical fissure, the fissure for ligamentum teres, and that will mark the lower parts of the liver for us. So we'll know if we're high, mid, or low in the liver. Now, since I mentioned ligamentum teres, let's talk about that. Ligamentum teres means round ligament. We have different round ligaments in our body, but this is the round ligament in the liver, which is the obliterated fetal remnant of the umbilical vein. So the fetal umbilical vein, once the fetus is born, there's no need for that vein, so the vein clamps down and becomes almost like a thick fibrous kind of cord located within a fissure, within the fissure for ligamentum teres. So the fissure has a little fat in it. That's what gives us bright reflectivity. So somewhere in here is the collapsed, obliterated ligamentum teres, surrounded by echogenic fat. This is a transverse section of the left lobe, and that becomes a divider of the left lobe into medial and lateral segments on a transverse scan. Also notice that there's some shadowing behind this, and the reason that it shadows is because, not because it's calcified, and this should not be mistaken for a calcified mass, but it's because the ultrasound beam strikes this at 90 degrees, which is directly striking this fibrous cord, and that shadows behind it. As soon as you change the angle a little bit, that shadowing will disappear. If it was truly calcified, there would be shadowing no matter what angle you come from. The fetal umbilical vein came into the umbilical segment of the left portal vein. We can see this when we cut the liver sagittally at this precise level, we are now taking a sagittal image, and we can see the brightness of the fat surrounding the ligamentum teres within this umbilical fissure, and notice that it goes directly into the umbilical segment of the left portal vein. So that's where the fetal umbilical vein enters the portal system. This vein may recanalize in portal hypertension, and once again, it is a divider of the left lobe. So while I mention fetal remnants, I'll mention the ligamentum venosum. Ligamentum venosum is the obliterated fetal remnant of the ductus venosus. The ductus venosus carried blood out of the liver. In the fetal circulation, blood entered the liver, but there was no reason to stay in the liver, so there's a ductus venosus that right away carries the blood out towards the inferior vena cava and towards the fetal heart. That ductus collapses once the fetus is born, and it lies within the fissure for ligamentum venosum. Now, here on a sagittal section, that fissure appears to be a bright line, which is located between the caudate lobe and the left lobe of the liver. Behind the caudate lobe is the inferior vena cava. Okay? When we turn 90 degrees and do a transverse section, the fissure appears here again as a bright echogenic line. Somewhere in here, we don't know where, is the collapsed ductus venosus, probably closer here to the umbilical segment of the portal vein. So it would have come out, and on higher sections, it will enter the inferior vena cava. Notice that that fissure is a broad plane. It's a line on transverse, it's a line on sagittal, so it is not a linear kind of fissure, but it's rather fairly broad. And that is our divider for caudate lobe from left lobe of the liver. This vein does not recanalize in adults. You don't see this vein ever again, except perhaps in the very small neonate that has umbilical vein catheters. You might see it, but once the child grows, this vein is obliterated and does not recanalize in portal hypertension. I mentioned the caudate lobe. When you think of caudate, you think of something caudal, but yet that's not really what this means. Caudate in Latin means tail. So the caudate lobe is like the stubby tail of a dog. Here's a little puppy here. And it's actually one of the more cranial parts of the liver. Now, we pay attention to the caudate lobe because the caudate lobe is functionally an autonomous segment, and it has often been said that it is spared in liver disease. It has its own blood supply. It takes blood supply from the right and the left portal veins, and you can prove this to yourself if you carefully scan. If you have a good patient, a thin patient, and you look around the portal veins, you can see small branches entering the caudate lobe, and you can also see venous drainage, separate venous drainage directly into the inferior vena cava. And supposedly that drainage here is what helps to protect the caudate from other diseases. Now, another thing you should know about the caudate is that it itself can look like a mass sometimes. We call that a pseudomass. Here's a section of the liver, and it looks like there's a mass in the caudate. So I would caution you, this is an artifact. If you ever think you see a mass in the caudate, ask yourself first, are you sure that that's not a pseudomass? What happens with the pseudomass, the ultrasound beam comes through the portal structures and becomes attenuated. So it partially drops out, giving it the appearance of a hypoechoic mass. If you move off of this porta and come in with the beam from different angles, you will see that this is not truly a mass.